So welcome everybody. Thank you for joining us for this postnatal contraception webinar. It's really amazing to see so many of you here. I am Heather Glossop. I'm a professional development midwife for the North West Maternal Medicine Network. And yeah, it's amazing to see so many of you here. We originally thought this was going to be a Northwest event, but word seems to have spread as far and wide as London and Belfast, and we're really thrilled because we're just excited that there's so many people who are interested and enthusiastic about postnatal contraception as we are. So if you're not familiar with maternal medicine networks, we're one of 17 in the country that were introduced in 2021 by NHS England, and our primary goal is to facilitate specialist MDT equitable care for women who enter pregnancy with a pre-existing medical condition or who become unwell during the course of their pregnancy. And to really sort of combine resources as a region and work together to strengthen maternal medicine services as a region. And so, of course, postnatal contraception is something that we're incredibly passionate about because we know that those short interpregnancy intervals are associated with increased maternal mortality and morbidity. And so this webinar that we're hosting tonight is part of a bigger piece of work that we're doing within the Northwest to improve access to postnatal contraception. And I've been working with Dr. Katy Sutcliffe and Dr. Amy Berry, who are our fantastic speakers today, to facilitate training for doctors and midwives on contraception choices and implant fitting, and to sort of support providers to implement contraception services within maternity. So yeah, we're thrilled to see you all. Thank you for joining us. We are recording the session, and so that should be available on our website in the next 1 to 2 weeks if you want to refer back to it. We'll also make the slides available. Also keep an eye on the chat because we'll be putting some resources in there. If you have any questions, then please just save them till the end, and we'll try and have a bit of a Q&A, or pop them in the chat and we'll try and answer some of them as we go. Without further ado, I'll hand over to our first speaker, who is Dr. Katy Sutcliffe, who's a consultant in community sexual and reproductive health in Chester. So over to you, Katy.
Thank you very much, and it's so lovely to see so many people here, giving up their Tuesday evening, and some familiar names and some less familiar names because people have travelled virtually from further away. So I'm going to be just giving you a bit of background to postnatal contraception and probably a bit about why I really care about postnatal contraception, because I do really believe it's a missed opportunity to prevent unintended pregnancies and prevent short interpregnancy intervals. The next slide. Thanks. So there's a lot of evidence that say 97% of women do not wish to conceive again within the first year of birth, and that should come as no surprise to anybody. And the reason I probably really got into postnatal contraception or really started to care about it is I was an Obs and Gynae trainee. My CCT is in Obs and Gynae, and then I shuffled across to CSRH when I got my first consultant job about 18 months ago. And when I was learning to scan, as probably many people learn to scan, the place to learn to scan is on an abortion list. And I tell this story a lot, and I'm sorry if you've heard it before because you've heard us speak before. But rather than learn to scan an EPAU where people are desperate to have some good news or know straight away if everything's okay, learn to scan an abortion list where the screen's turned away from the patient is often a good place to learn to scan. So I was like ST2, ST3, do an early pregnancy scanning, and it was just really remarkable how many women would come in with like a 3-month-old baby, they'd be upset, their baby would be upset, they were pregnant again and they didn't want to be. And I used to just think, we've failed these women. Like, these were the women that we saw in antenatal clinic and we've just delivered a few weeks ago, and we've said, off you go to your GP, get some contraception sorted, and it's not happened, and they've ended up pregnant again really soon, when we know the data shows most women don't want to get pregnant again in that first year. The next slide. And we know, or hopefully most of us know, that contraception is required from day 21 postnatal. Most women don't know that. We surveyed them on the postnatal ward, and we got such a range of answers of when would you need contraception postnatally, from immediately to like 6 weeks, 12 weeks. And I think 6 weeks is a common misconception because of the 6-week check, but obviously there's that sort of interval where people get caught, don't they, between 6 week, between day 21 and 6 week check, because the earliest expected date of ovulation could be from day 28. So the idea is to have something in your system beforehand. Next slide. And this is the common response when you try and talk to women immediately postnatally about contraception. And this is where I really advocate for antenatal counselling, because immediately postnatally they're completely overwhelmed. There's so many other things to think about. But we know that this isn't true, and women do have sex again. That's how we see multips. And have the next slide. Yeah. Because by 6 weeks, 41% of women will have had sex again. This is UK data. I've got all the references I can share. And by 65% by 8 weeks. And there's a whole range of reasons that women will resume sexual activity perhaps earlier than we anticipate they will, or certainly that they will anticipate they will immediately postnatally. Next one. So there's national data to show that 1 in 13 women who book for antenatal care or for an abortion in the UK have given birth in the previous year. And when we did a local survey when I worked in Liverpool of patients attending for abortion care, it was 1 in 7 had given birth in the previous year. Next one. And so we should really care about short inter-pregnancy intervals, because it's associated with low birth weight, with stillbirth, with maternal morbidity, including anemia, organ failure, and admission to intensive care. And this was the sort of big sell when we started these conversations with the Maternal Medicine Network about this, particularly for high-risk women who you have cared for intensively in one pregnancy, and then they are pregnant again quite soon after. Next one. Read this quote fairly recently, and I think it just really highlights the feeling amongst women that dealing with a newborn and really not wanting to get pregnant again and not necessarily having those options and choices. Next one. So we'll all be familiar with the Embrace reports, saving lives, reducing inequalities. Oh, my echo in there, I don't know what's going on. But Embrace specifically mentions the lack of contraceptive counselling for women who've had multiple high-risk pregnancies, and urges clinicians to offer contraception to those women with complex medical problems and comorbidities. Next one. And so it's not just me telling you that postnatal contraception is important. It's agreed by the RCOG, that is the all-party parliamentary group on sexual and reproductive health report. It's in the Women's Health Strategy for 2022, and just published last year was the reimagining the Beyond Barriers, reimagining access to post-pregnancy contraception. I'll share some of these things in the chat when Amy's talking, but that was a joint document by the COSRH, which was the FSRH until the last summer, and the RCOG, which has got a document sort of about implementation. It's got a document more for commissioners and people who fund it, and I really think that they're worthwhile things to read and be familiar with, and to be sharing with teams and people who've got money and can make a lot of decisions locally, wherever you are. Next one. So it's the most cost-effective thing you can do in public health, across all of public health, not just maternity. So for every £1 spent, there's a £32 return on investment, which is, it's in the Women's Health Strategy. So generally contraception is a good thing to do from a public health point of view, but specifically contraception in maternity sense is particularly cost-effective. Next one, please. And everybody thinks somebody else is going to do it, don't they? It's frequently pushed back to the GP. GPs thinks it should be sorted out in maternity, so some people get signposted to sexual health. But it's that old adage, that's the word. If everybody thinks somebody's going to do it, then nobody does it. Next slide. And when everyone thinks the GP is going to do it, obviously there's lots of things for a GP to cover in that postnatal check. There's 13 different areas that are highlighted in the NICE guideline for what could be covered in a postnatal check. And often they are a combined mum and baby appointment, so baby can have immunisations as well. They're not always done at 6 weeks. So there's lots of barriers in just pushing it on to GPs. We know cost is really Can I go back again? We know that cost is really complex due to fragmented commissioning. It's contraception kind of sits between local authority commission services, which commission sexual health, and the ICB, which commission health type services, and it can fall down that gap. And it's not insurmountable because there's some places in England, even with English commissioning models, that have managed to do this. We always cite time as a barrier, but we can probably find 10 minutes across a whole maternity care journey to have a conversation antenatally. I recognise that time for training is a barrier, and I appreciate most people are probably giving up their own time this evening to do this. And we've really tried when we've done our daytime webinars to ensure that they are on working days and that people are getting that time back. We know there's a lack of knowledge and confidence amongst midwives especially, but probably amongst obs and gynae doctors about discussing contraception. I did my master's dissertation on this about confidence to initiate contraception discussions and how to do it. So hopefully events like this can just help people feel a bit more reassured about the confidence, what they do know already, and signpost you to useful resources for filling in some of those gaps. Now I'll have that slide, thanks. So this is borrowed from Michelle Cooper in Edinburgh, who says the 3 pillars of postnatal contraception are provider training, which is hopefully what this is, giving people a bit of an introduction, having informed discussions with women, and then having the choice of method available before discharge. And there's data that shows about 25% of women want to have contraception before they're discharged from maternity settings. So it's certainly not for everybody. We're never sat here saying that everybody needs to have contraception, but women need to have choice, and it needs to be an informed choice. I think that was my last one. So things that we will share is the CSRH guideline contraception after pregnancy, which has got pretty much everything you would need to know. There's a free online counselling course, which is free e-learning that you could do. And these are things that can be shared with other people. There's a new UK MEC, so new UK medical eligibility criteria that was out in December, so just be aware of that. And then on e-learning for health, there's ESRH, which has got some really good e-learning and has a module on contraception for specific populations, which includes contraception after childbirth as well. So I think that's all the things I had to say. I'm going to hand over to Amy to do lots of the nitty-gritty, but I will continue to man the chat and comment and contribute there. Thank you.
Thanks, Katie. So let me just share these slides and make a start. How's that looking? All good and moving okay?
Great, thank you.
Great. So Katie does what I call the hearts and minds part of this presentation, because we have kind of always said that post-pregnancy and postnatal contraception is a real hearts and minds thing where, like Katie was saying, there's lots of opportunities where this can be done, but it's no one's real job and it falls through all the gaps. And actually, a lot of people that we talk about really agree with this. They agree that it's a good thing, it's something that we should do, but because it doesn't really fall under anyone's direct job, or it does in lots of different ways, no one actually gets assigned to do it. So we kind of go the 2 approach with this, where we do try and get you on board and make you believe that this is a really good thing that we should be doing, but then also give you a bit of information about practical things that you can do. So think of this as your contraception 101 for what you can do. We're going to have some tips and tricks of things that you can do now. We know that this isn't perfect. We know that commissioning is a problem, but there are some examples of really good practice out there. So basically this is to kind of give you the energy to sort of push for this in your units if it's something that you believe in, like we do. So I'm Amy. I'm a community sexual reproductive health trainee in Liverpool, and that means I'm based between the Women's Hospital doing some acute gynae, early pregnancy, abortion care, and within sexual health services doing some complex contraception stuff. So the College of Sexual and Reproductive Health is my version of RCOG. And basically what we do is we look after women throughout their reproductive life course, and that's from birth to death. And it covers all of these different things that will be relevant over their life course. And essentially, they produce some really useful information for us. And like Katy was saying, those beyond barriers documents have things in like this. So some infographics of sort of good stats that kind of prove that these are things that is worth doing. So we'll put links for all these things in the chat, but there's lots of really good advocacy documents and stuff to look into. But information about the fact that we know people are having unwanted pregnancies, we know people are going for an abortion within the first year after having a baby. So it's just thinking about practical ways that we can help people. And there's also a few comments in it. Basically, got a combination of women and midwives and contraception providers who basically are saying, yes, this is a great idea. So if you need something, that's somewhere to go to show it to commissioners and consultants where you work. And then if you need a full-on guideline, again, the COSRH have a contraception after pregnancy guideline. So if you need all the detail, looking for the nitty-gritty information, this is where to go for that. So the reason that we look at this with Maternal Medicine Network is because we all know that people will have patients in their pregnancy who they are desperately thinking about, staying up awake at night, hoping that they'll get them through this pregnancy, and with complex medical conditions that they're worried about them, and they're worried about them being healthy and safe in their pregnancy. And obviously, the main thing for them is that we kind of think once we've got them through that pregnancy, we don't want them to get pregnant straight away again. We want them to be able to manage their conditions, do that pre-conception sort of counselling, and get like a good plan in place. And this is recognised in that FSRH document, and it says some conditions that may pose a significant risk during pregnancy include all of these ones that I'm sure you know about, but it also says to try and emphasise LARC in these people just to help them to plan their pregnancies in the future and make them safer and healthier for them and their babies. So thinking about introducing methods and how we talk about this. And as Katy said, it's great if we can do this antenatally. We know that on a postnatal ward, which is often kind of where it's happening at the moment, ad hoc, is where people have got a crying baby and they're recovering from their delivery and they've got everyone else coming around to see them and really they just want to go home. So actually trying to introduce these antenatally is a good thing, but if you can only do it on the postnatal ward, still do it there. So some people might find it a strange thing to try and talk to people about in their pregnancy, but what we kind of recommend is sort of phrases like this. So things like, as much as you're pregnant now and you might not be thinking about it, it's a good time to talk about what you might want to do when you have a baby if you don't want to be pregnant soon again afterwards. There are lots of different options available if you want to talk about them, and we can send you information. If they want to know the most effective methods at implants and coils, we'll talk about that in a bit. But a phrase that I quite like to use in these scenarios is be like, we can arrange this for you, or we can help you get this, because I'm sure people think I get paid £20 for every coil I fit, and I absolutely don't. But I think that kind of thing of what Katy said, this is not for everyone. Not everyone will want to go home with something, and you also don't want to like force things on people, but kind of saying like, can we help you? Is there anything that we can do to make this easier for you? Is sometimes quite a nice approach. And the other phrase that I quite like saying to people is like, you're not married to your contraception. You can stop it when you want to. You can come back and see us. You can change this. This doesn't have to be it forever. Just so people know, and if people are a bit worried about side effects, then they've got that kind of information with them. So a couple of ways that we need to think about it in terms of making sure that we do this safely and effectively is the woman right for the method? So are they safe to be on it? And is the method right for the woman? So will they like it? So safety first, I always think, because you might as well, there's no point going down a rabbit hole of telling someone that they're going to have a depot injection and then finding out that they are not eligible for it. So might as well find out what they're safe for first. So you should all be familiar with the UK MEC. So that's the UK Medical Eligibility Criteria. There are 4 categories. 1 is absolutely crack on, go ahead, it's all safe. 2 is benefits generally outweigh the risk. 3 is theoretical or proven risks might outweigh the benefits. If there's no other options, you might want some expert opinion. So you might want to speak to a patient's other healthcare professionals. You might want to speak to us in sexual health, or you might know loads about this yourself and you might feel comfortable about using something in a UK MEC 3 if nothing else is suitable. And a UK MEC 4 is we shouldn't use it and it's unacceptable risk. And it's just a reminder that this fits to contraception purposes only, not gynecology. And then there's a little section like this. So this is your post-pregnancy section of your UK MEC. It's a really long document. This is your post-pregnancy bit. And then what I've done is put little circles around the 3s and 4s for you, so to see what things we're not going to use. So ultimately, within the first 6 weeks postpartum, we're probably not going to use a combined pill. So I'm not going to talk about that loads in this, because really what we're trying to do is give you the tools of things that you can start in a hospital setting. I know GPs may be starting this later down the line, but we're going to kind of get rid of combined pill for today, because most people we won't be able to start it in a hospital setting. Something that's changed recently, and we're quite upset about it, but that's what the evidence shown, is the depot injection. So the depot injection used to be a 2 postnatally. It's gone. So you can still use it providing people have no other risk factors for VTE. So that means that our VTE risk is 0. So that's because we've had 5 new studies that have shown an increased risk of blood clots with depot injection. And we've also had one specific study that does show there's about a 2 times increased risk in the postnatal period, which we know is a high risk time for VTE anyway. So unless they're completely not suitable for anything else, depot injection is not the perfect option you're looking for unless someone has a VT score of 0. And obviously this all goes in to say that ultimately the thing that would give someone the higher risk of having a VTE is if they got pregnant again in that time. So that's why this is all a case of saying, you know, it's pros and cons and trying to pick the right method. And then the other bit I'll point you down towards is the section down at the bottom of the screen. So this is specifically about coils. So you can fit a coil at the time of delivery, or within the first 48 hours. So that's at the time of a C-section or at the time of vaginal delivery. You can fit a coil within the first 48 hours. After that, it's waiting 4 weeks afterwards, and that's just due to a higher perforation risk in that time. The way that you fit coils postnatally is different to a routine coil fitting, and we're going to talk about that later too. So that's kind of overall. So everything else, as you can see, your progesterone only pill, your implant is safe. So they're 2 really good options. Your depot is safe, providing someone doesn't have any additional risk factors for VTE, and your coils are safe, providing you fit them within the first 48 hours or 4 weeks later. So that's kind of your rundown of safety. And then just in case there are any other things that you were thinking about in terms of other medical conditions that are related to pregnancy, none of them are a problem long term for people. So no problems there. This section I'm going to skip through a little bit, but these are just a reminder of medical conditions that might interfere with contraception. So I'm going to skip through some of these because actually most of these relate to combined pill, but I just wanted you to have them there so that you've got a bit of an idea of things to think about. So same with these. We'll talk a bit more about drug interactions later on. But what I thought we'd focus on is actually the main progestogen contraindications, because like I said, we're not focusing on the combined pill today. So the main reason someone can't have a progestogen is if they've had a previous stroke, a previous heart attack, breast cancer past or present, or liver cirrhosis and tumours. And that's just one way you might want to check the UK MEC again for more details to see, but they're the main contraindications to having a progestogen. Depot has got a few extra new ones and I've listed them all here. So, and again, this is mostly to do with the fact that we've had those additional 5 studies that have shown that increased risk of VTE. That's because with the depot, we give you a big dose of progesterone at one time. So that's why we think the risk of VTE is higher. The mechanism isn't known. We still not work that out. But there are a few extra medical reasons there as to why people can't have a depot. So just keep an eye out for those. Most of these people would score on your VT risk assessment, so you're already going to rule them in and out that way. So they're the things you're looking at. If you're looking for resources for this, there's, like I said, there's the UK MEC and there's a summary table, and we'll give you a link to that in the end. There was a lovely thing called the UK MEC calculator, which I think might get up and running at some point soon, but they've closed at the moment because the new UK MEC only came out in December last year. So they might get up and running again, and it was a nice little calculator where you could put in all the medical conditions and it'd list all the numbers down the right-hand side. But at the moment, not available, but hopefully again soon. So that's kind of your safety overview. And then we're looking at, is the method right for the woman? So this is kind of now about explaining methods to women, giving them the option, and then seeing what actually may or may not work for them. And this is kind of like the art, not the science part to contraception. So what if someone comes to you and they say, I have no idea what I want? In that case, you might want to think about what would they like to consider? Is there any hard yeses and hard nos? Have they tried anything in the past? Have they talked to anyone before? Have they had any previous issues? So you might want to go through these things. But what I found is I kind of split it up into these kind of questions for patients. So hormonal versus non-hormonal. So have you got any specific preference? Have you had any good experiences with hormones? Have you had any bad experiences with hormones? If you've got loads of time to debunk some hormone myths, please feel free to do it for us. We know there's lots of problems with a big shift towards non-hormonal methods, and we agree, we know they're not for everybody, and we know the methods aren't perfect. However, just that reminder, and again, I know that you know this in gynae, but they help with lots of other conditions too. And it might be a time that you kind of say, oh, well, any of these problems, are your periods a problem? Is your skin a problem? Is PMDD or PMS a problem? And actually, hormones might help with some of these. So have you got any specific preference? There's no point trying to convince someone to take a pill if they desperately don't want hormones. So have a little chat about those things. Bleeding pattern is another good one to try and pick apart for people. So is irregular, unscheduled bleeding going to be an issue? Because most progesterone-only options will give you some form of irregular bleeding pattern. They're likely to get a little bit better with time, but they're not perfect and they won't really give you a regular pattern. What someone's periods like to start off with, are they heavy, are they painful, would they benefit from a hormonal coil or any other hormonal method? Or if they are heavy and painful to start off with, you might want to avoid a copper coil. And then not so much in the sort of postnatal period, but for some of us in contraception, we like to identify any underlying problems before starting contraception. That's mostly related to if we're worried that bleeding is cancer related, which obviously is really uncommon in this population, but there is a mention in the UK MEC about that. And then long acting versus short acting. So long-acting reversible contraception is what it says on the tin. It acts for a while and it's immediately reversible. So I tend to put coils and implants in this section. Medium acting, I tend to put depot in there because it lasts for sort of 12, 13 weeks, and it does have a delayed return to fertility. Short acting, so your pills, your barriers, your patches, your rings, your diaphragms, things like that, and then your permanent options. So do people want a longer period, like longer time between their periods? So do they want to go for, are we kind of thinking, actually, I want to really space my pregnancies out, I want a long time? Are they wanting something shorter that they can stop themselves at home? So getting that kind of information helps you like guide patients towards options that might work for them. And then effectiveness is also something that people might want to think about. So what's your primary concern? Is it you're really, really like certain that you don't want to get pregnant? And is that really important to you? So kind of talking to people about your most effective method. So if people kind of want a list of it, so your most effective method is your progesterone only implants. Following that, it's in line with vasectomy. And then after that, it's your looking at your hormonal coils and your depots. And so what I tend to use when I talk to people about methods is I tend to use typical use because we know people aren't perfect and we know people aren't using the contraception perfectly too. So I'll often use the typical rates when I talk about how likely you are to get pregnant when you're on a method of contraception. And these, by the way, have just been updated with the new UK MEC, so they have slightly changed a little bit with some newer data. So they've changed ever so slightly, actually, to show that things are probably a little bit more effective typically than we thought they were. So you might want to talk to people about how effective their method of contraception is. And then you can use diagrams like this to demonstrate that. So it might be that people want to like look at something visual to get an idea of what's the most effective method. And then when it comes to discussion options, this is kind of my layout of how I do it. So it's what is it? How effective is it? How it works? Good things, bad things, risks if there are any, and then teaching them how to use it. So that tends to be my like contraception template layout of how I will talk to people about things, and it gives you a really good counselling for your patients. So that they know effectively. And I think a lot of the problems that we have with people is they are always told like, oh, I was just given this pack of pills and no one told me any of these side effects and now I have all these problems. I think actually, you know, if we set expectations, prepare people for it, explain things to them, they're much more likely to get on with an option or be agreeable to them, or recognise problems and stop it if it's not for them. So this now is your contraception 101. So what are the options? And I'm going to go through them and kind of keep your like key points on here. So progesterone only pill is a great option postnatally because you don't need to do anything other than feel comfortable with the information that I'm giving you today and be someone that's a prescriber to give this out. So the progesterone only pill that you're going to give out is normally desogestrel. That's the most common one that we use now. Its mode of action is to stop ovulation, to thin the lining of the endometrium, and to thicken the mucus at the cervix. And stopping ovulation is what this does on top of the older pills that used to exist. If you use it well, it's pretty good and it's pretty effective. And we know that realistically, missed pills is the problem here in terms of people taking it effectively. Good things about it. It might help bleeding control. Some people will get no periods on this, but prepare people. They might have some irregular bleeding. See how they get on after a few months of it. If they don't like it, they can stop that themselves at home if they wanted to. Cons, we've already talked about the bleeding. We'll talk about hormone side effects in a second at the end. And then risks, we know that there's a small increase of risk of breast cancer with most of our hormonal methods of contraception that goes down to being minimal after we stop them. And then when you talk about teaching pills, what I normally say to people is I try and keep it simple. There's lots of missed pill rules. What I tend to tell people is, you know, this is a pill. So the desogestrel pill has a 12-hour window. That means if you were going to take it at 9 a.m. in the morning, if you've not taken it by 9 p.m. at night that day, you've missed your pill and you're not protected from pregnancy. You need 48 hours of protection until you're good to go again. So you need to be on your third pill and that's when you're good to go again. So that's how I normally teach it. And I just say any missed pill is a concern. That's what you do and you take it from there. Same goes if you vomit within 2 or 3 hours of taking your pill, or if you have really bad loose stool, then that's would class as missed pills too. The Lowdown is a website that's got a missed pill calculator. It's also got lots of like patient feedback about contraception, but the Lowdown has a missed pill calculator. It's endorsed by the college and people can put their pill in when they last took it, when they had sex, and they can work out if they needed emergency contraception or if they need condoms going forward. I normally tell people, put it by your toothbrush. It gives you 2 chances a day to take your pill. Injection, so that's Depo-Provera, which is medroxyprogesterone acetate, or Ciana Press is the subcut version of this that people can give to themselves at home. Works in the same way as the progesterone only pill. It is more effective because it lasts for longer, so you're not as much in the risk of sort of missed pills. But the reason that people typically might it may be less effective is because you don't come back for your next injection on time. So pros, it might stop your periods and you only have to come so the guidelines sort of 10 to 14 weeks. We normally aim for about 13 weeks for most people to come back and see us, but it gives them an extra week to try and get to us if not. The cons about it, so the main actual things to think about here is delayed return to fertility. So we tend to tell people it may take up to a year for your fertility to come back. That is not true for everybody, and some people on week 15 their fertility will come back. So what we'd normally tell people is if you're planning for a pregnancy in the future, maybe switch onto something else about a year before you want to get pregnant. There is a small link to increase weight on the injection. It tends to be in our under 18-year-olds, and we've found that if people do increase weight in the first sort of short period of time of being on it, they're likely to continue to do so. So we do counsel people on that. We know that there's a small reduction in bone mineral density whilst you're on the injection. It doesn't seem to correlate to fracture risk at the moment, and we find that again it goes back once you've been off the depot for a few years. And we'll talk about side effects later. And teaching it is, like I said, every 12 to 14 weeks to come to sexual health for an injection, or like I said, they can do that subcut injection themselves at home, and we normally would give them a year's supply of that to do. Implant, so it's a small flexible rod that goes in the upper arm. It's effective for 3 years. Mode of action is the same as our other progesterone methods. It's the most effective method of contraception, so perfect and typical. Only 1 in 1,000 people would get pregnant in a year, so it's a really good method of contraception. The good things about it, so all those things, people may get a good bleeding pattern. It might improve their other gynae conditions. The main con and the main reason people do come to us to stop it is bleeding pattern. So irregular or erratic might be what people find with it. And again, just prepare people for that and just say, look, your bleeding pattern is going to change on this. You might get no periods, you might get irregular bleeding, or you might get frequent bleeding. I'm not worried about any of it most of the time. However, if it's irritating you, come and see sexual health. We'll talk to you about things that we can do about it. And sometimes what we do in these people is we add on another pill, so a combined pill or a progesterone only pill, to try and settle down the bleeding. Some people think that's a bit counteractive, because why would you want to have a pill on top of an implant? But ultimately, that's down to your effectiveness. Like, you've got a very effective method of contraception. If that's your main concern, then actually it doesn't matter if you miss a pill, because all it's doing is trying to look after your bleeding. So that is an option for people that have got problematic bleeding on an implant. Procedure wise, we just talked about small risks. So they'll get a little scar, a bit of bruising, infection, a small risk of infection, hematoma, very small risk of deep insertion, migration, damage to nerve and blood vessels. These can be fitted on the postnatal ward before you go home. So after your baby's delivered, you can have one of these fitted before you go home, and it will be effective immediately for you after you've had your baby. So that's something that realistically we can do on postnatal wards. It is definitely been starting to be done in different hospitals across the country, and we do it here at the Liverpool Women's Hospital, and that's been part of a project to improve our postnatal contraception. So we've now got something like 8 implant fitters in the hospital, and we've got 5 more midwives who have got some training via the maternal medicine network. So that's definitely something that we can strive to do before people go home. And then coils. So different kinds of coils are available. The main ones that you'll probably know about are Marina. You'll probably start to hear about Levocert because they've got the cheaper applicator. And Benelexa is kind of in between, and they're made by different drug companies. And then there are 2 slightly smaller ones that you can use as well. Their main mode of action is thinning the lining of the endometrium, thickening the mucus at the cervix. They don't particularly stop people from ovulating. About 80% of people still ovulate with a coil in place. They're really effective. People like them. They're long acting. They're really good for gynae conditions. They will pretty reliably reduce your bleeding, and I don't need to sell a hormone coil to most gynecologists, I'm sure. But we obviously really like these as an option. They're not perfect. Some people will bleed and spot every day and get irregular bleeding. They don't like them, but they are a really good option. The risks, so risk of perforation, so it's about 1 to 2 in 1,000 normally. That's about 6 in 1,000 if people are postnatal and breastfeeding and come to us at that 4-week mark for an insertion. And the expulsion rate's about 1 in 20, which is kind of higher than you'd think it would be. And again, we think that's probably higher postnatally, including fits at the time of delivery. Small risk of an ectopic pregnancy. So if people get pregnant on this method, small risk of an ectopic. Again, I tend to tell people you're at less risk than the average person walking around not on contraception, because you're less likely to get pregnant. And small risk of infection, as with any procedure. And then we'll talk a bit about this later, but these can be fitted at the time of C-section. They can also be fitted at the time of a vaginal delivery. And then I said we'd talk about hormone side effects. So lots of people will get different hormone side effects. The way that I kind of tend to counsel people on this is like, you might get some side effects from hormones. People are different. Your friends are different. People that you talk to will react to these in different ways. But things like headaches, skin changes, breast tenderness, bloating, change in bleeding pattern. If it's anything that you don't like, come and see sexual health. And I can't promote sexual health clinics enough in this talk. I obviously work amongst different systems, but when I'm based in sexual health, I get long appointment times. I'm really well supported. We have lots of knowledge about contraception. You're basically seeing a specialist without needing a referral. So I really can't promote the services better to people. Utilize them, they're great. But what most patients will probably care about and will want to know about is things like mood, weight, and libido. And again, I tend to talk about these because I find that people don't want to feel ignored about them. So what I tend to say is that all the evidence that we've got hasn't shown a huge link to our hormonal contraception and these things other than the depot and weight. However, people experience hormones differently and people react to them differently. And you may feel like your mood, weight, or like sex drive has changed whilst you've been on a method. We know that there's lots of different factors that will influence them. But if you don't like this and this isn't suiting you, you're not married to your contraception, you can change it. So kind of addressing those things and being like, we can change it, we can do something about it. What are the options non-hormonal? I'm going to kind of speed through these because I know we're getting towards the end. So copper coil, really good, really effective. Same thing, we can fit them at the time of C-section and vaginal delivery. They're non-hormonal. People will get a regular period, but they might be more heavy and painful. Barrier methods, so things like condoms, obviously, like these are good options for people. They protect you against STIs. Their typical effectiveness has actually gone up since most of the time I counsel people, I tend to say about one in 5 people will get pregnant using condoms in a year. The typical effectiveness has changed, so we're closer to 1 in 10 now, which is better. So yeah, these might be all someone wants when they leave hospital. They might just want some condoms. Just a quick note on diaphragms. The Kaya diaphragm is what we tend to use now. You use it with some spermicide, but we don't recommend it until 6 weeks post-delivery when the uterus is kind of back to pre-pregnancy size. And then quick note on natural family planning. So we don't recommend it postnatally just because your cycles haven't kicked back up again, and it will take you a few months to learn what your cycles are doing. That it can be really effective if you use it properly, but we know most people don't, because the way to use it effectively is to combine a few different methods. So things like the calendar, so tracking your cycle, checking your temperature every day before you've got out of bed, eaten food, done anything, waking up at the same time, you've not drank alcohol, you're not unwell, checking your temperature, and then things like cervical mucus and cervical position. And all of that still means that you shouldn't be having sex in the first half of your cycle before you've ovulated. So most people aren't following that. What they're doing is checking the Flow app and seeing when they've ovulated. So it's just, if people are going to use this, that's absolutely fine. It depends how effective they want, but tell people that there's actually quite a lot more factors to it if they want to use it properly. And then again, I won't emphasize sterilisation too much because I know you probably know a lot more about this, but obviously that option of sterilisation at C-section, and obviously the male option of having a vasectomy, and that's a really good option for people. It's more effective, and it's more effective than female sterilisation. And then lactation amenorrhea again, potentially is a really good option, but remind people they have to fit these criteria. So they're fully breastfeeding with minimal other feeds of like juice and things like that. So fully breastfeeding 4 hours in the day, 6 hours at night. They've not had a period yet, and they're less than 6 months postnatal. And then bridging methods. So that's something that the kind of term that we use when we're talking about using a method of contraception whilst a patient is waiting for what they ideally would like to be on. So either the method's not available, so they can't have that coil because they've not had a C-section, and you don't fit vaginal coils after delivery. You've not got an implant fitter available, or they're not suitable for that postnatal depot anymore. So this is looking at giving someone something and being like, we know this isn't permanent, but we're just giving you something to get you through to your next appointment. Progesterone only pill is the most common method used for this because it's got few contraindications and it's easy to give it to a patient and it's cheap. So quick note on medications wise, just as a heads up. So enzyme inducers, I've listed some of the important ones there. People that are on enzyme inducers, the things that aren't affected by them are depots and coils. And then teratogens, we want you on a really good method of contraception, so that is implants or coils. If it's both of them, then ideally a coil or a depot and condoms. But again, that information is all somewhere else. I kind of want to skip on to the putting it into practice bit. So this is a bit about what you can do as an obs and gynae doctor or hospital doctor, SHO, GP trainee, whatever you are on the postnatal ward or working with pregnant people. So discussing things in antenatal clinic. So I kind of use this as my like brief intervention bit, the same as you would with smoking when you go, oh, have you ever thought about quitting smoking? Just say, oh, like, have you had to think about what contraception you want after you've had your baby? Go have a little, these are some websites, go and have a read, have a little watch of this video, think about things that you might want because we can help you with it before you go home. Offer IUDs fittings at C-sections if you're able to in your hospital. So some hospitals will be doing this already, some will have follow-up pathways, some will be doing it ad hoc. So just see what your trust is doing and see actually if it's something that you're really interested in, see if you could set up a pathway. So we'll talk a little bit about this in a second. You can train to fit implants, so you can do a letter of competency to fit implants. It's not super expensive, it's about £120, and then you pay a membership to the college and you get lots of extra things with that. And then you do essentially a bit of online learning, watch a model arm demonstration, and then you watch someone fit one, and then you have to do 2 or 3 supervised fittings, and then you can be signed off to fit implants. So they're something that you can train to do. You can counsel women on the postnatal ward after delivery. So with all this information that you've got today, you can go and speak to people and say, oh, would you like a progesterone-only pill, a depot, or an implant if we've got it available? And you can talk to commissioners and talk to your CDs in your hospitals and say, this is something that's important. Can we do it? Look into funding agreements. So just as an example, in Liverpool, our local authority team, so basically the people that normally pay for sexual health, have provided the ICB, so the people that normally pay for the hospital stuff, with money, because what they're saying is these women would normally see us in the community, and you're actually doing us a favour almost by fitting that contraception before this person has left the hospital. So in Liverpool, the local authorities get pay back the money for every device, so every implant and every coil that is fitted in hospital, they give that money back to the hospital to say you fitted it there. So involve your local authorities, involve public health in this. There can be some really great people that will work on this, and including the team in Liverpool. What if you're a midwife? So you can counsel women at antenatal clinic, and you're the one that might see people regularly and just be able to say like, oh, have you had to think about that? And we know that every appointment is busy and every appointment has got so many things that you need to do in it, I'm not saying you need to go through the ins and outs of every method of contraception. It's just a case of signposting people to the right places, letting them know what's available, and giving women choice. If you're more interested, you can attend one of the essential contraceptions following childbirth courses that are done by the College of Sexual Reproductive Health. Sometimes they're done locally, and me and Katy and Nikki, who's one of our other consultants, have run them locally. We've run them with the Maternal Medicine Network. So they're available. They are available online as well. But sometimes in your local area, you might find someone that will run one for your hospital for you. You can look at adopting the PGDs. So there's national PGDs for contraception. So you don't need to do anything extra to them. They already exist. The hard work has been done for you. You just have to get them through your hospital's medicine management system and get your pharmacists on board. But actually, if your midwives have done a little bit of extra training and they've been done these extra courses and things, then actually you might feel like it's suitable for them to give out some depot or some progesterone only pill on the postnatal ward. And if you wanted to, you could also do those courses, like I mentioned, to fit implants as well. So these are all kind of things that you could do if you wanted to. And then I said we talk a bit about coils at the time of delivery. So coils at delivery are safe and effective. They've got no increased perforation risk because actually the myometrium's thicker at this point. They have got a higher risk of expulsion. So that's why I said you should probably really look at having a follow-up pathway in place. And there's a few things that would mean we wouldn't do it. So if you have a prolonged rupture of membranes, unresolved PPH, obviously you don't want to go and pop a coil in there. Or if someone's septic, then you don't want that risk of infection because you might need to remove that coil anyway. So you don't want anything else in there to make that worse. And like I said, you kind of could do with having an agreed follow-up pathway, and different hospitals do different things. So some people will have agreed with their GPs that they'll get seen for a thread check and a speculum with them. In Liverpool, we've got an agreement with our sexual health service, so they get fitted at the time of C-section and they get a referral out to our community sexual health services. They get a scan at 6 weeks. If the coil's in the right place, happy days. If it's not, they got offered to have it replaced on that day, which is a great service for them. And we find that actually of the people where it's in the wrong place, 80% of those chose to have it refitted on the same day. Or you might want to bring them back to a service within your hospital in outpatients. So what we do at C-section, so you add it to the consent form and then you place your coil. So you take your coil out of the applicator device. So this is my bid to use Levocert and not Mirena, because the whole difference in price is that Mirena's got a nice little applicator and Levocert has got a two-handed one, which is fine to use still, but we know it's a bit fiddly. In this, you're not using the applicator, so use a Levocert, they're cheaper. So you take it out the packaging, you hold it, so some people do it between the finger and thumb, some people hold it between sort of their first two fingers, and they push it up towards the fundus, and then with their other hand they'll feel on top of the abdomen, so you can feel that you're pushing at the fundus a little bit like you would do fundal pressure. So feel in there that you've got it there, and then you're going to direct the threads down towards the cervix. So you can again do that either with your fingers or with some forceps. You don't need to push them through fully. You don't need to do a speculum afterwards to pull them through. You just guide them down towards the cervix. And then, like I said, have an agreed follow-up. And then, yes, you can do that with either hormone or copper coils. You need to obviously give your patient the information of what you fitted, when and where they're going to have the follow-up, how long their coil lasts for, and what device they've got. And ideally, again, the contact of someone that if they're having problems with it, that's where they go to. I'm going to leave that because I think we're running a little bit short of time. We're going to pop all these resources so you can watch that video later on. Coils can also be fitted at vaginal delivery, and it's really not very widely offered around the UK, but NHS Lothian, so Edinburgh, is a really great example of somewhere that does this. It's a different insertion technique to a routine coil, so you can't just go in and pop a marina in with a normal applicator after delivery, because obviously we know the uterus is much bigger at this point. So again, I've popped a video in for you here in case this is something that you're interested in, but essentially you take your coil out the applicator and you put it on some Kelly's forceps, and then you insert it vaginally after delivery of the placenta. So essentially, whilst you've still got your epidural or your gas and air and your legs in the stirrups, you deliver the placenta and then fit the coil. And again, I'll let you watch the video in your own time of how that's done. Ultimately, like you need specialist training for this. So for coils at C-section, if you had that pathway and agreement in your hospital, you could start doing that tomorrow. This one needs some specialist training, and again, at some point in my lifetime, I'm going to go up to Edinburgh and train how to do it, and I'll come back and bring it to the Northwest. But at the moment, that will be something that I'll do in the next hopefully year or so. But this is something that you can do. And that's the video for it. So again, we'll pop all those links in the chat for that as well. I'll skip through. And then this is an example of a follow-up pathway. So this is what they do. So NHS Lothian, like I said, have shared loads of their resources. So they've shared their SOPs, their patient information leaflets, their coil insertion checklist, and this follow-up pathway. So they don't actually scan everybody afterwards like we do in Liverpool. And there is no specific recommendation in the guideline that you have to do that. But you need to have them followed up in a service where that would be the option if you were worried about the risk of partial expulsion of your coil. So I'm just, again, we'll put all these bits in the chat for you to have a look at, but these are kind of the resources that you can look at in terms of options to follow someone up that you fit a coil for. And then again, I'll leave this one for you to look at later, but again, this is another video that's been done. It's about 2 minutes long. It's lovely. It's a really nice video for patients about postnatal contraception, talks briefly about the options, but it also addresses those kind of things that I was talking about at the beginning, where I said, like, sometimes this is a funny thing to talk about with women when they're pregnant, and it addresses that really nicely. So this is something that you could play in your antenatal clinics, probably with no sound and some subtitles on, and it also comes in different languages, with like the subtitles in different languages. It's a really lovely resource for people to use. And then I'm going to skip through that one. And then,
Amy, sorry,
okay?
I'm so sorry to interrupt. Just to say, we are scheduled to 8:30 if
Oh,
you
are we?
didn't want to rush.
I was rushing on because I thought it was 8 o'clock. Oh, well, we'll have time for questions anyway. And then this is also something that a little project that I'm starting to work on with Kaylee, who's one of our GP trainees. She's probably on the call somewhere. And she's got a future leaders role and has been looking into postpartum contraception campaigns for people. So something to get a bit more information out for people that have been pregnant and about the options that are available. So there's a little code there for an Instagram page that we're going to be developing and putting more content on in the coming months. And there's also the post-birth contraception network, who again are a group of people who have either are wanting to develop their services, are doing really good things, or are trying to get a network together in order for us to share this work. Because again, there's no point reinventing the wheel. Lots of places have done this and have got things like SOPs and stuff in place. There's no point reinventing the wheel. We might as well share all the information that we've got when we already know this is a tricky area. So they said to me that if we put down there, they've got their like a code for a Teams link. You have to have an nhs.net email, but if you're interested in it otherwise, you can contact me about it and I can put you in touch with them if you wanted to be part of that network. But yes, this hopefully will be a resource for patients, and we'll probably have some healthcare professional stuff on there too, about a campaign for postpartum contraception. Briefly, I just want to talk about other post-pregnancy contraception as well. So there are other people that may want contraception. So if you've had a miscarriage, if you've had a termination or an ectopic, you actually might not want to be pregnant again. So you can again start the methods after you've had these things. So a few little tips and tricks here is that most methods are effective if started within 5 days following you having treatment. You can have a coil fitted at the same time as your surgical management of miscarriage, your surgical termination, or your laparoscopy. You can have an implant fitted at the same time as mifepristone. You can also have a depot at the same time as mifepristone, although there's a little bit of evidence to show that you might have it may be slightly less effective, as in the mifepristone less effective, not the depot. So they're options for people. And again, I think it's one of those things of just saying, remember that people that are having a miscarriage may not have wanted to be pregnant in the first place. They might want to have a bit of a gap in between trying for a pregnancy again, if whilst they sort of recover from processing that. Obviously, if you've had a termination, we should be offering you contraception. And the same with an ectopic, you might just want a bit of time to recover. Or we might be giving you methotrexate and telling you not to get pregnant for 3 months and then not sending you home with any contraception. So that's just a reminder there that actually make sure you offer those people contraception if you're going to tell them not to get pregnant for the next 3 months. And then I've got a couple of quick bits on gestational trophoblastic disease. Again, rarer things, but just so that you know, in terms of kind of when we advise you to not be pregnant. So after a complete molar pregnancy, we advise for at least 6 months after treatment. If it was a partial mole, after you've had 2 normal HCG levels, or if you're having chemotherapy, then it should be a year after you finish treatment. And again, just in terms of things that people can have after gestational trophoblastic disease. So you can have, if you've got undetectable HCGs, you can have anything. And then if you've still got raised HCG, we just avoid coils, and that's due to a theoretical risk of you perforating when you fit a coil and disseminating the disease, or because of higher bleeding risk in these patients. So that's the reason behind that. I've sped through that because I thought we were finishing at 8 o'clock, not 7:30, but hopefully that probably gives us a little bit more time for questions potentially. And then, so this was just my reminder to say that we'll send out a feedback form, we'll get your certificate, we'll answer some questions, and then they're mine and Katie's email addresses if you've got any extra questions. But if I stop sharing my screen, then I guess if there's anything in the chat, we can probably think about answering some questions. Sorry, I've done that at like 1,000,000 miles an hour.
Was fantastic. Thanks so much, Amy. That was brilliant. And Katie, your presentation as well. Brilliant. I think Katie's done a brilliant job of keeping up with all the questions in the chat.
Oh, has she?
There's one here. Could you please clarify, for patients that have methotrexate for ectopic, are POP and implant the only suitable methods?
No.
No. You can have anything.
Yeah, you just want something really reliable. So yeah, if there's not, just follow the UK Met and other contraindications. I'd be sort of more keen for them to have a LARC, really, depending on what they want. But yeah, there's no interaction between methotrexate and the other options. And it's specifically detailed in the contraception following pregnancy guideline.
Brilliant, thank you. And then another question. So there's no current easy way of training to do vaginal delivery IUD insertion.
Not that I've found. It's something that I'm on the lookout for. So I've been in touch with a colleague in Edinburgh, and I'm probably going to go up there and do the training with them. But they've got there's something called the Mama U, which is like the training model that they use. And so you do have to go up to somewhere that will train you for it. So you do some training on a Mama U model, and then you have to be around on a labour ward for, like, again, the same kind of thing, sort of 3 people that want a coil fitting. So it does involve that kind of like lurking around for it. So I guess it's the same with anything. It will start small, and as people go and train, things will get bigger. FIGO have done a big project looking at this in different countries. So they went to like 6 different countries and trained lots of people to do this. So it's not impossible, but yeah, it's not like a super easily available training right now. But hopefully, it's something that I'm planning on
You
going
may
to do.
have colleagues that have trained overseas.
Like, I was going to say, you might just know someone.
When I did obs and gynae back home, we used to just fit them at vaginal birth. So it requires Kelly's forceps, which have been kind of the rate limiting step. But there's not like a letter of competence or a specific route as such.
There isn't. And then the other thing I've done in my stalking for things to try and do for postnatal contraception is found something called the pop-in trial, which looks like it's going on again at Edinburgh at the moment, where they're looking at a longer coil inserter device, so you wouldn't have to use those forceps. So they're going to extend the length of a coil inserter so that they can do that, but again, it's currently a trial. So, but again, hopefully as things get developed, things will become easier and we can disseminate that as well. I'm trying to think.
Fantastic, thank you. Just a few more questions. Is there any local Liverpool women's training for implants?
So the way that kind of implant training works is that currently the College of Sexual Reproductive Health have their letter of competency, and that is what most of us will do and follow in order to fit them safely and feel like we've had the appropriate training to do that. We know that some places are developing their own local training. It's difficult because that might mean that you may go somewhere else that deems that not acceptable. So at the moment we don't, and we just have people, so trainers that will watch you and supervise you to get signed off for the college letter of competency. So that's what we're doing at the moment, and unless you have funding elsewhere, it's currently self-funded, but that's what the Maternal Medicine Network have been amazing for, because they've been funding some training for implant fitting. So at the moment, we're when you come to us at the Women's, we're your supervisor, but we supervise you to do the college pathway for it.
Thank you. And just from a network point of view, we don't have any of the study days planned at the moment, but if we do within the next financial year, then I'll make sure I email this group, because obviously you're an interested group. So, but obviously it would be open just to Northwest practitioners. But yeah, I will make sure that reaches all of you if we do manage to put some more on. I've got another question here. If people have mood side effects from hormonal methods, is it appropriate to offer Mirena? But I've seen people who develop hormonal side effects from Mirena. Is there any solution to this, especially if they have endometriosis or heavy periods and hormones are the only way to fix their symptoms?
It has to be a try it and see approach. There's no definite way of knowing whether or not you're going to have hormonal side effects from a Mirena if you have from a pill. I think I do a bit of education around that. It's a much lower dose of hormone in a locally acting method, and it predominantly acts locally on the lining of the womb, but there will still be some systemic absorption. You get some women who are particularly sensitive to progesterone, who will have mood effects from it, but the guidance and my personal practice is to have a conversation with them and try it and see. I suppose it's different when you are using contraception for endometriosis or heavy periods, because it's your risk benefits, isn't it? And about what people can tolerate. So not a hard and fast answer.
No, and I guess that anecdotally you could use the smaller, your J-Desses and your Kylenas. I don't know, again, there's probably no quotable difference in hormonal side effects, but if someone was really sensitive and really was keen to have one, I guess in theory you could try a smaller device and see how people got on with them, because it's even less hormone. But there is a slightly smaller amount that's in your circulating blood volume with those options. But yeah, I get, like Katie said, I guess it's trial and error and seeing how people get on with things. Yeah, and until I guess the same things will happen, we'll come out with new progestogens, new things will keep coming around. It's just everything takes a little while.
Do you know how many women in the Scottish unit opt for immediate coil insertion?
Do you know what? No, I don't, but I can probably find out.
You could definitely find out, because it'll be published, because Sharon Cameron and Michelle Cooper are really good at publishing every step of what they've done.
Yeah, exactly.
So, they have obviously different funding situation and different commission in Scotland, so being able to get on with this work for a while. But one of the early things they did was the Apple study, which was about access to postnatal LARC in Edinburgh South. I think that's what it stands for. And that started with the counselling women about contraception. They've just built such a big pathway, but they've got loads of really good evidence behind a lot of it. So that definitely will have been published, but I just don't know the numbers off the top of my head.
Thank you. And do you quote 5% risk of expulsion with coil inserted at C-section or more? And do you trim the coil threads?
It is definitely higher, and I will tell people it's higher. I think the actual numbers, again, there isn't really a stated value on the college website. We probably don't have enough data to say how many that is. I do tell people it's higher than that. From Liverpool, we're finding it's probably about 1 in 6, so it is higher. Which sometimes people respond to me and they're like, well, why are we doing it? But 1 in 6 is still 5 people that have got a coil in place when they left. And like I said, for the people that we do follow up, 80% of them still say yes to having their coil changed, and they might never have come to see us before. So it is definitely higher. And again, we don't have a definite number for you, but I do tell people it's higher. And then in terms of trimming the coil threads, not at the time. So after you fit it at section, you don't have to trim the threads. If you do them vaginally, you can, but if you do them at section, you don't need to trim the threads afterwards. But when they come back that's why you do need to organise a follow-up for them. So they do need them a speculum, and then saying, and then they can trim them at that point. So at that point, you just trim them to the normal, like 2 or 3 centimeters afterwards. Some people will find that they come out of the vagina completely and beforehand. So I normally just say to people, if that's the case, just bob to your GP and they can just trim them sooner for you. So yeah, sometimes they do find that they come the whole way out of the vagina. They can obviously tuck the threads back into the vagina if they don't want them hanging out and they don't want to risk pulling the coil out. But yeah, then we'll trim them afterwards.
We've adopted the Liverpool SOP in Chester as well as a trial. So I see these people, and I think that's the advantage of somebody who can scan, who can fit a coil and can trim the threads, seeing these people for follow-up rather than sending them to a sonographer for a scan to then make an assessment to send them somewhere else to trim their threads, or somewhere else again if they need to have a new coil inserted. So it's that kind of one-stop shop for follow-up, because women with a small baby have got enough already. And we chose that model, didn't we, of scanning people postnatally to check that their coils were correctly sited, just because it's kind of like a new thing here and we don't have that evidence just about the expulsion rate just yet. So for that reassurance for patients, so not to rely on it until you've had a scan. And I suppose that's because that's the difference with Edinburgh, where they go for just a coil thread trim, don't they, later on, because they've got that expertise that they built up by having quite experienced practitioners fit those coils over a number of years, and we're not there yet in the Northwest.
Thank you. We've got some helpful comments here from Deborah, who was answering Wafa's question. Warrington Hospital are trying to set up implant training for midwives, and we're in discussion about this with commissioners, so that's fantastic news. And Jean's just sent an updated list on the enzyme-inducing anti-seizure medications.
Oh, that's amazing.
And another question here, do we need a letter of competence to fit coil at section?
No, you don't. Nope.
Just be trained to do it. It's useful if you've got something in your portfolio. But that's where that question comes up about, why do obs and gynae trainees need a letter of competence for implant fits when they don't need one for coil fits? How the jury is out on that.
Yeah.
But you've got to be able to demonstrate that you're competent if you have a complication, don't you? So
yeah, so something on your e-portfolio to reflect on the fact you've done it and you've been trained, that you've seen someone do one, or someone's shown you how to do it and you've done it.
And Anna has said, Leeds Sexual Health, we saw an expulsion risk of 15% in the first 120 patients with coil at C-section, and the main complaint was vaginal threads at the vaginal introitus.
Yeah,
that's really helpful to share. Thank you.
I think I did see something where people were like, you could trim it to the introitus, so like patients could trim them themselves just to the introitus if they wanted to. So whilst they're waiting to be seen by someone.
And what are your views and evidence for secondary care providers for chronic condition management getting involved in postnatal contraception provision?
What do you mean, like cardiologists, if someone's got a cardiac problem, or I'm not quite sure what that question means.
Janine,
I think with contraception, there's really good guidelines to follow. So I think if you're a doctor and you feel competent to do it, and you're going to follow the FSRH guidelines and not make things up, because I think that's what upsets me, is when people who aren't specialists in contraception tell patients they can't have a certain method, and there's actually no evidence for that. So if you're going to follow the evidence, I think it's reasonable.
And I think you feel
to
like you have
start,
that
isn't it?
role in like you know, that pre-conception care, because you look after patients with like medical conditions where you really don't want them to be pregnant. It might be that as part of your role in pre-conception care, you have that kind of like counselling on contraception with people, because you've been looking after them, trying to not let them get pregnant when they're not ready to be from a medical point of view. So it might be that if you have that extra knowledge and experience, and your patients trust you, they look after, you know, you see them often if you've got chronic conditions, and they'll trust your advice. So again, like you might feel really well placed to have those conversations with people.
Yeah. And DFSRH is open as well, isn't
Yeah,
it? You don't have to
yeah,
be an obs and gynae doctor or a GP. Any doctor
not at
can do
all.
that. I've recognised Janine's name because she's like the epilepsy specialist.
Oh yeah.
Who I've sent lots of letters to back and forth over the years. So yeah, happy to pick up a separate conversation, Janine, if you want to.
And loads of them are open to not just medics, like nurses, other healthcare professionals. So the diplomas and the locks are open to other people.
We've trained a pharmacist, haven't we, on the
Yeah.
postnatal ward at Chester, with the Liverpool women's, who's been a real great advocate, done the FSRH, really interested in contraception, is an implant fitter. So it's not just necessarily doctors and nurses.
And we've got an amazing PA at the Women's Hospital as well, who has also done the diploma and also fits implants. And because she's basically permanent staff on the postnatal ward, she's our go-to implant girl. Like as soon as someone wants one, she's off there fitting it. She's great. So it's just finding the right people to train in your unit.
Do you cover with another method until scan at 6 weeks to check in the right place? Yes, you should do. Yes. I would advise people to use condoms.
Yeah, so we do advise that, because if they turn up and it's in the wrong place, then in theory they've got a pregnancy risk. So, and if you're following strict guidelines of when you should be fitting coils, you shouldn't be doing it if someone's got a pregnancy risk within the last 3 weeks, because their test won't be positive yet. So if they do come and they've had sex in the last 3 weeks and their coil is in the wrong place, we can't change it on the same day. So it almost feels counterintuitive, because we're saying like, oh, we're giving you a contraception, but yet don't rely on it yet. But again, it's that extra thing to mean that someone might have something that they keep long term.
Is there a role for a specialist nurse follow-up following coil fit at section, or is it consultant follow-up? It's me, I'm a consultant, and my colleague Rani, who's a specialist doctor. But if you had a specialist nurse who could scan, who could fit a coil and could do a speculum, yes, it could be done by a specialist nurse. I agree.
Yeah, and our main limitation to that is probably the scanning in sexual health, isn't it? Because at the moment in Liverpool, we're like we said, we're scanning them all. As we're doing this as a pilot, and we're making sure that things are in the right place, and we're doing it as properly as possible. We are scanning at this point, so that would probably be rate limiting set potentially, as if you're a sexual health nurse or a specialist nurse and you've not scanned before, and scanning coils particularly as well.
Exploring training anaesthetists do implants. Well, they are head end, aren't they? Like, it's reasonable if they're trained. Or like, if you can cannulate somebody, and they're pretty good at cannulating people, it's pretty easy to fit an implant. You just don't want to do it in the same place you would cannulate somebody. But yeah, there's a.
That's great, I think.
Option. Anything else anyone else wants to ask? Even out loud. I don't want to hear anybody else's voice.
Yeah. And I think all the little, I made like a little resource list for us, but I can see that I think everyone's kind of posted things in the chat as we've gone along with all the videos to watch. There's loads of really good resources. So I can see that Katy and Kaylee have both been my like cheerleaders in the background, posting all the things that I've been talking about as I went along.
I aim to post all the things that you said, Amy, that you'd sent me, but everyone beat me to it anyway. But I can send them out as well, links with certificates. So I'll send those out. You'll have certificates and links by the end of this week.
Great.
Are there any final questions for Katy and Amy? Some lovely comments. Thank you very much. I've just popped the QR code, and I'll pop the link again for the feedback if you could could kindly fill that in, that would be really helpful. Thank you. But if there's no further questions, then we'll let you all go. But thank you very much for joining us. It's been fantastic to see so many of you here, and just get in touch if we can help you in any way at all. But thank you.
Thank you. We'll stay around for a few minutes if
Yeah.
anyone else thinks anything.
Yeah.